All right. Okay. Good afternoon, everyone. Welcome to our last LEAD seminar for fall 2018. And before I introduce our speaker, I wanted to make a really quick announcement that our first seminar of spring semester 2019 will be on January 14th, which is a Monday, and it is prior to the start of the academic year. But I'd encourage you all to attend because Matt Gilman from NIH will be here to talk about the ECHO program. So without further ado, I'm really excited to introduce you guys today to Dr. Ferrara, who is a senior research scientist at Kaiser Permanente, Northern California Division of Research. Dr. Ferrara is known for her epidemiological and translational research in relation to diabetes and gestational diabetes, so she's in really good company here. Dr. Ferrara and her colleagues led a study where she adapted the diabetes prevention program intervention for use in pregnant women, so namely those that were obese prenatally and postnatally, as well as those with gestational diabetes. And she does also conduct cohort studies among pregnant women and their children in order to understand early life risk factors for obesity-related conditions. Now, in addition to her research inquiries, she has led and established and maintained the Kaiser Permanente Gestational Diabetes and Pregnancy Glucose Tolerance Registry. It's a mouthful. And this registry has served as a really rich resource to identify determinants and consequences of gestational diabetes, both at the level of healthcare infrastructure and also biological consequences and risk factors. So now I'll hand the floor over to Dr. Ferrara, and please join me in welcoming her.
Okay, thank you for the introduction, and thank you for inviting me to present this data from my research. And we all know that diabetes in pregnancy has increased during the last 2 decades. And this is of serious concern because it can amplify, this increase can amplify the vicious cycle for diabetes and obesity. So as this vicious cycle shows, women with, who have a pregnancy complicated by diabetes are at higher risk to develop diabetes later in life. I can use the mouse? Yeah. Okay. And women with diabetes, either gestational diabetes, that is hyperglycemia, first diagnosis during pregnancy, or with the pre-existing diabetes before pregnancy, are increased risk to have a child that is too large. It's called macrosomic or large for gestational age. This poses the child at the increased risk of developing childhood obesity. And as a consequence, its complication like diabetes, there will be more women who enter pregnancy with overweight or obesity. The factor per se that put at risk of having a macrosomic or LGA infant and increase also their risk to develop gestational diabetes during the pregnancy, thus perpetuating the vicious cycle. So this increase, this vicious cycle, really call for upstream prevention of diabetes. And lifestyle intervention before, during, and after pregnancy may prevent or mitigate health risk associated with diabetes and obesity during pregnancy. But in order to have a population effect, we need to work across the translational research continuum, where basic science, epidemiology, and efficacy randomized clinical trial may inform a more generalizable, pragmatic randomized trial, with a long evaluation of health program may lead to implementation and delivery science, and hopefully to positive changes in clinical care and policy. So how we translate research on diabetes in pregnancy to break the cycle? This talk focus on 3 major themes. 1 is identify the diagnostic criteria for GDM. 2 is knowing the prevalence of diabetes in pregnancy. And 3 is testing scalable upstream diabetes prevention. Starting with the first point about the diagnostic criteria of gestational diabetes, I see many young people here, so many of you would not know the history of this very discussed topic about how we diagnose gestational diabetes. These slides show the three major set criteria: the National Diabetes Data Group, the Carpenter-Custon, and the International Association Diabetes Pregnancy Study Group criteria. Originally, the National Diabetes Data Group proposed the diagnosis of gestational diabetes via an 100 gram of GTT during pregnancy, and set this cut point and require at least 2 abnormal values for the diagnosis. Later, Carpenter-Custon used the same test, but they lower each of the cut point for each of the glucose values. It is by using the Carpenter-Custon criteria, we can see there is an increase in the prevalence of gestational diabetes. When I started to work at Kaiser, the National Diabetes Data Group were the only criteria used in all Kaiser and many other clinical settings, given the lack of evidence that the Carpenter-Custon criteria were associated with increased perinatal complication. So we conducted a study among 45,000 women. We did not meet the National Diabetes Data Group criteria, so they were not treated. And we conducted 3 nested case control studies showing that women who had 2 or more abnormal values, according to the Carpenter-Custon criteria, were not treated, had substantial increase of having infant with macrosomia or hypoglycemia or hyperbilirubinemia. Later, the Appm study was published, an international study including approximately 25,000 women that were tested by 75 gram oral glucose tolerance test. And they showed that the association between pregnancy glycemia at each time point, fasting 1 hour and 2 hours, with several perinatal outcomes, including large for gestational age year, was a continuous. So the International Association for Diabetes in Pregnancy Study Group shows the odds ratio 1.75 to select that was associated with the perinatal complication to select that it is a cut point for the diagnosis of a GTM. In addition, they require only 1 abnormal value. As you can see, the adoption of this criteria increased dramatically the prevalence of a GTM. And there was a lot of concern about whether the health system had the capacity to take care of so many women. And also, there was not sure whether this, the association with between these glucose values and the outcome was mostly related to the upper end of the glucose distribution, which included the Carpenter-Custon criteria. So we conducted a study again in Kaiser, where we look at the association of large for gestational age across level of glucose for each time point of the GTT. And also we look at association among women who met the Carpenter-Custon criteria were not treated, and women who met the NDGG criteria were treated. And here we can see the women who met the Carpenter-Custon were not treated actually had higher odds of having a child with LGA. The women who were treated had the higher glucose values according to the NDGG, suggesting the treatment may improve the outcome. We also observed that those who had isolated fasting hyperglycemia here, according to the Carpenter-Custon, had an increased odds similar to the CNC to have an infant with LGA, suggesting that isolated fasting can be used for to identify women with gestational diabetes. Two randomized trials have been conducted so far on the treatment hyperglycemic during pregnancy. Above this trial, that was conducted among women with severe GDM. The second trial led by London was conducted among women with mild GDM, showed that treatment decreases some perinatal outcome, including LGA macrosomia. This provides the first evidence that this cycle can be broken if intervention are done. We provide also additional evidence whether treatment works also outside the clinical trial, right? Where you have a lot of problem with the representation of the women participating by evaluating a telephonic nurse management in association with the outcome among women with GDM. And we saw that in the medical facility, referral to the telephonic nurse management, 70% or more of the patients with gestational diabetes had the decrease of macrosomic infant. I want to spend a few words about this nurse management because I will come back later for another study. So it's called the Regional Perinatal Service Center at the Kaiser Permanente, North California, include nurse and dietitian. It provides supplemental care to women with gestational diabetes by telephone counseling on glucose monitor and control, diet, and exercise. The patients receive 2 to 3 counseling calls per week. So going back to the continuance of the we show that through epidemiological study, we show that the Carpenter-Custon threshold and isolated fasting hyperglycemia increases the risk of LGA and macrosomia, that through evaluation health program, the referral to nurse management for pregnancy hyperglycemia reduce the odds of macrosomia, which lead in this implementation. The adoption of the Carpenter-Custon criteria for the diagnosis of the GDM, and the referral of all patients with gestational diabetes to the nurse management. However, there are still some gap in our knowledge and on this topic. We still need to conduct a large study to evaluate the comparative effectiveness of treatment modalities of gestational diabetes on adverse outcome. There are different options of medication for the treatment of gestational diabetes, and we don't know what is the long-term effect on the children, especially related to childhood obesity and neurodevelopment. And also, we need to evaluate the effectiveness of early diagnosis and treatment of gestational diabetes on adverse outcome. It's because gestational diabetes is diagnosed usually during the 3rd trimester, and there is concern that it may be too late for the treatment to have a positive effect on the children's outcome. So the other important theme about translated research on diabetes is the prevalence of diabetes in pregnancy to plan resources for treatment and prevention. In the early 2000s, we showed that the prevalence of gestational diabetes had increased by almost 50% from 1991 to 2000. And also, we discovered clear racial and ethical disparity, with Asian having the higher prevalence of gestational diabetes, followed by Hispanic and then African American. We also show an alarming increase of pre-gestational diabetes, so women who had diabetes before they became pregnant, with an 82% increase overall from 1996 to 2014. And we observed that both pre-gestational type 2 and pre-gestational type 1 increased, had a high rate, 85 and 73%. The increase of type 2 is consistent with the increase of type 2 diabetes, which has been reported among women in reproductive age. And the trend in increase of type 1 is very consistent with what was reported in the youth in the United States participating in the search study. When we do the analysis, I don't go into detail, but when we do the analysis compared by race ethnicity, we have very similar increase. So this increase basically can have a snowball effect on the vicious cycle that I showed before, right? Because if the in utero exposure to diabetes increase the risk of childhood obesity and diabetes, of course, will be continue to perpetuating the cycle. So that's why we need to test the diabetes prevention program that start early in pregnancy. But then in order to have a population effect, it's important that they are scalable. So the DPP trial showed that the diabetes prevention trial showed that in sub-analysis of women with gestational diabetes showed that both intense lifestyle intervention and metformin reduce the risk of the incidence of diabetes. However, women included in the study had a pregnancy on average 12 years prior to randomization. So it was not informative about how we can break that vicious cycle. In order to do that, I think we have to do intervention that start during pregnancy and continue postpartum, not only to prevent diabetes and possibly macrosomic in LGA infant, but also the possible recurrence of gestational diabetes. So based on epidemiologic studies showing that type 2 diabetes in women was strongly linked to postpartum weight retention. So women didn't lose the weight they gained during pregnancy. And that a strong risk factor of postpartum weight retention is a gestational weight gain. We designed an intervention for women with gestational diabetes, called DEBI, that started during pregnancy, soon after the GDM diagnosis, and the women were given the goal to adhere to the IOM guidelines for gestational weight gain, and continue postpartum, where women were given the goal to either return to their pre-pregnancy weight, if they were normal weight, or lose an additional 5% if their pre-pregnancy weight was in the range of overweight obesity. And we showed that women in intervention here in light purple were more likely to meet the postpartum weight goal. And at 12 months postpartum, there was an absolute difference of 60% between the two conditions. And because our hypothesis was that if we help women to gain appropriate gestational weight gain during pregnancy, they were more likely to meet the postpartum weight goal. We did repeat analysis, stratify women in those who did not exceed the IOM recommendation and those who did exceed the IOM recommendation. And we saw that the intervention was more effective among those who did not meet the IOM recommendation, when 22% absolute difference in the proportion of meeting the postpartum weight goal. So coming back on our continuous, with an efficacy randomized trial, we show that the DPP-derived intervention reduces postpartum weight retention. So the Perinatal Center was very excited about that. It included some educational material to be mailed to all women with gestational diabetes about how to prevent diabetes postpartum. This also gave the opportunity to us to conduct another study, a comparative effectiveness diabetes prevention strategy to reduce postpartum weight retention, when one group was those receiving the mail from the Perinatal Center, and the other group will be an adaptation again of the diabetes prevention program. This was a cluster randomized study, so where the unit of randomization was where the medical facility. So we randomized 44 facilities, including approximately 2,500 women with gestational diabetes. So the intervention was delivered by lifestyle coaches. We were sitting at the Perinatal Center. It was presented as a new Kaiser Permanente program for women for GDM. The IRB waived the consent, so women didn't know they were in the study for the intervention component. They received a survey, but that was named in a different way. And so we compared the two strategies, where the intervention started during pregnancy via a tailored letter on gestational weight gain, continued postpartum with 13 telephone sessions, and the women would be given the same primary goal, like in the DEBI study, going back to the pregnant pre-gravid weight, if normal weight, or lose an additional % if they were overweight or obese. So since they didn't sign up for a study, was presented as a regular program, we wanted to look how much was the uptake. And you can see here that 50% completed at least one telephone session, while 15% completed all 15 sessions. In an efficacy trial, this could be very bad, but in a pragmatic trial, it's very good because basically is evaluating a program beside a healthcare program. In the intention to treat analysis, so include everybody, those who participated and did not participate in intervention, we showed that during the 12 months follow-up, women in intervention here had a 24% increased odds of meeting the postpartum weight goal. And we saw that this difference was statistically significant also at 6 weeks and 6 months postpartum. So although the primary outcome of the trial was postpartum weight goal, we want also to evaluate the effect of the tailored letter on gestational weight gain, on actual gestational weight gain. And we saw that women who were randomized to the facility, were randomized to the intervention, were 8% more likely to meet the IOM guidelines for weekly rate of weight gain from GDM diagnosis to delivery. And we show that they had a lower risk of having a large for gestational age infant. Then we conduct some mediation analysis to see how important was the gestational weight gain component to our primary outcome, the postpartum weight retention. So we showed that the GEM multi-component intervention reduces postpartum weight retention, that the letter during the pregnancy helped women to meeting the IOM recommendation for gestational weight gain, and that the proportion of the intervention effect on postpartum weight retention mediated by meeting the IOM recommendation was approximately 25%. That is quite high in the mediation analysis. So this basically reinforces our original conceptual model to start the intervention during pregnancy to help women not to manage their gestational weight gain and then continuing postpartum. So going back to the continuum, so we our translational research. So we show that the DPP-derived intervention reduces gestational weight gain, postpartum weight retention, and LGA, women with GDM. And now we're working with the clinical leader to implement gestational weight ladder and to organize some postpartum referral to weight management for women with GDM. There are other places in this vicious cycle where intervention can be done or it can be broken. This includes interventions in pregnancy with overweight and obesity. And there have been, before the Life Mom trial, there were several interventions. They were not successful. But the Life Mom trial, it was a consortium of several types of intervention, as you can see here. They showed that intensive lifestyle intervention reduced the proportion of women exceeding in the Appm guideline for weekly rate of gestational weight gain. And they also they see all the intervention more or less, those who were able to recruit here had the same effect. And with a sample size of more than 1,000 women. However, besides this larger sample size, they didn't see any effect on change on health behavior, as well as neonatal outcome, including larger for gestational age or macrosomia. We also have an ongoing, we just completed actually, the GLOW trial. We applied for that grant for the Life Mama. We didn't get it, but we applied for another one soon after. We got it, half of the money, but we could do whatever we wanted. So we are 1 year later. We just completed the intervention of 396 women. Among women with overweight or obesity. The intervention also is very translatable because it includes only 2 individual persons and 11 telephone calls. We gave the goal to women to gain a minimal gestational weight gain, not to go over the lower bound of the gestational weight gain range recommended by the OIM. So it was 15 pounds for overweight women and 11 pounds for obese women. And we saw that the women in intervention were less likely to exceeding the IOM weekly rate of gestational weight gain. And we got a huge 20% absolute difference between the two conditions. We also showed that women intervention were less likely to exceed the IAM guidelines for total gestational weight gain, with even a bigger difference between the conditions. Also, we have the intervention, the positive effect on several secondary outcomes, including health behavior. It reduces sedentary activity, total calorie, as well percent of calorie from fat. That was our hypothesized outcome because we're the base of the diabetes prevention program. But also we saw reduced in many other diet components. Have a positive effect on maternal metabolic profile. It reduces fasting insulin, or insulin resistant measured by HOMA-ER and leptin. It also improves the metabolic profile in the cord blood by reducing C-peptide and leptin. And it's very nice that, so there is not the same things we've seen in the mother, the insulin. Yes, C-peptide is a measure of insulin and leptin, they go together. So we were very glad to add the GLOW trial, oh, not yet because it's not published, to along with the Life of Mom trial in this picture as a possibility to break the vicious cycle. However, still remain, we didn't see also, forgot to say, any effect on macrosomia on LGA, very, very tiny. And if we massage the data, we do, but no. So this means that probably much larger sample size needed to do that, because birth weight doesn't it depends on many other factors besides gestational weight gain. Or probably we need to start to do preconception care to reduce the macrosomic or LG. Go ahead.
For Asia, birth weight may not be the right outcome. It might be
Yeah, there could be too, but they didn't find. We didn't find anything with the skinful leader, and also yes.
Did you, in addition to measuring meeting IOM criteria or the amount of excess weight gain, did you analyze what was going on with the blood sugars as well to see what?
Not yet. I just finished. Yeah, there is a lot of things to see. It didn't reduce GDM per se, a little bit, but not significantly. Also, no, yeah. But anyway, no, sorry. When we did the analysis for glucose, doesn't reduce glucose. We had glucose at 2 time points. And only the OMIR was reduced. So maybe it will be better not to start preconception intervention to have a positive effect on the outcome. There are a couple of ongoing intervention during the preconception period for women with overweight or obesity, but I'm not aware of any study or intervention that is ongoing and in preconception period to prevent gestational diabetes. There have been some intervention during pregnancy to prevent GDM. Many of them didn't have any effect. A couple of them, I forgot the citation, sorry, they have a very minimal effect. So this is another area probably that maybe in order to prevent GDM, also here we need to start before pregnancy. But in order to start the preconception care to prevent GDM, it's important to identify women who are at risk. And here I switched a little bit the talk to a core study, the PETALS study, where it's a pregnancy cohort. And we just published this paper last week showing that central obesity measured by waist-hip ratio is predictive of gestation. But this was measured very early in pregnancy at 10 weeks. It's predictive of gestational diabetes and improve the predictability of gestational diabetes above the conventional risk factor for GDM, where age, race, BMI, family history of diabetes, previous GDM, and pre-existing hypertension. This is very important because we saw also in women who didn't have any of this risk factor, waist-hip ratio was so predictive of GDM. It is very important because otherwise, usually these women are not considered for screening or for be targeted for prevention. So I would like to show here the PETALS pregnancy cohort, since it has a very similarity to the Health Start. And we just, by the end of December, we will finish our recruitment of 3,300 women. The study has two assessments at 8, 13 weeks and 69 weeks, where we collect fasting blood and urine. Everything happened before the diagnosis of gestational diabetes. It was originally designed for a nested case control study of 300 GDM cases and 600 control. But there where we are measuring several factors, but all women have the biospecimen collected, since we didn't know we was going to develop GDM as well, the questionnaire. Yes?
So, Asia, you have 300 GDM in a cohort of 3,000?
Yeah.
Is this general population?
We selected the facility where the prevalence was higher. It's enriched. The prevalence was higher. Why?
Asian American.
Yeah, almost half, 40% are Asian, yes. And so in both PETALS and the Healthy Start are in the ECO study, so you will learn a lot, as I understand, the next month. And that is an initiative. It's called Environmental Influence of Child Health Outcome. It's a national wide research program that will include 50,000 children. And we look at this outcome, including obesity. But it's very important to know the fact that we'll have the capacity to better understand the etiology of childhood obesity, and leading to possibly having the potential to identify more targeted strategy to prevent childhood obesity and its complication. We know Dana is an ongoing study on childhood diabetes prevention, right?
Yes, we do. Kate is not here because her kids are sick, but she's leading it. Kate Powder.
Yeah. You started already or no? Oh, yeah, great. So maybe we can be able to put a study in the vicious cycle again and to ways a possible break. So anyway, and I would like to thank you everybody for your attention and the organizer to give me the opportunity to present this data, and all the people who work with me. Without whom it would be not possible to produce so much and so many data. Thank you.
Questions? Wonderful talk. The work that you're doing is fabulous.
Thank you.
One thought that came to mind, have you followed up the women who were in the trials who were either brought into interventions either during or after pregnancy to see how they did in subsequent pregnancies and whether they were able to meet IOM recommendations on weight gain in subsequent pregnancies or prevent GDM?
Yeah, that's a very good question. We applied, we didn't get funded, but we welcome to the club. But we can do that. We are planning to do that electronic. We're using the electronic medical record, actually. That sometimes you get less information. You cannot collect many confounders like diet, physical activity, but also help you to have less selection bias in follow-up studies. So that's what we want to do, to see if they have, get pregnant again, the risk of developing gestational diabetes.
Translation of Epi into practice, and I'm wondering if you have any pearls of things that were successful or not so successful in trying to convince like clinicians to actually practice.
So one very important thing for the translation in clinical practice is that you need the clinician to work with. And it's very important to include them from the beginning of the study and give them some weight in as well. Not much, because no, said nobody needs me. So, for example, here we have a Dr. Yvonne Kreidis, who was, and she just retired, and was the director, medical director of the Perinatal Center. And she was an obstetrician with training in internal medicine. And that was very unique. So she went very beyond the obstetric issues, we say, and very involved on prevention. And I mean, without her, the study would not be possible. I mean, when I told you, described the GEM study that was delivered on behalf of the Perinatal Center. Even the person was paid by the funding of the grant. But we used their facility, the telephone, the letterhead, and so you need to establish a good collaboration before you even started. Even the intervention on gestational weight gain in overweight obese women, this was very important. For example, they wanted us to use the lower bound of the IOM recommendation for gestational weight gain, because for the grant for safety, I proposed the middle one, because people say, yeah, you cannot say ask to gain too little. And but that is very important. And then you have to go back to them, present the data, and then all the business cases started. And they want to adopt this ladder, but I mean, we need some resources. So you have to believe they don't know. If they don't have a person that's really passionate at this, they cannot find it otherwise. Yes.
What type of research questions this population may help us to understand of neurodevelopmental outcomes? And another question is, what's your specific culture competent intervention strategy for Asian Americans?
So the first question was how we do assess neurodevelopmental outcome. So we will, we didn't do any assessment here, but we will do in the eco studies very in-depth assessment. And actually we are fortunate enough that we have a very early blood sample because the neuron embryo have the neuron and the brain to develop first, so we can look at the exposure at that time of the development. But many studies that started later in pregnancy, they were not able to do that because they collect the blood, for example, at the time of gestational diabetes, and that was the third trimester, which was too late. For the Asian and for the Asian population, that's also for the other race ethnicity, we consulted with people to be respectful of the traditions. Actually, the nurse director, Jenny Ching, to the Perinatal Center was very vocal on that. And also, the type of intervention we do not prescribe. They're all based on motivational interviewing. That is a technique that empowers the participant to come up with their decision on how to change the behavior and what. So it's not a dietitian saying, you have to go to walk half an hour every day. How you find it? I help you how to find a time on what you would like to do for a physical activity.
Can I ask you what, I thought you just referenced cultural reasons for why Asian Americans might not be receptive to the intervention. Did I make that up?
Yeah. I hope not. I will be in trouble in San Francisco.
I thought you said you were consulting with
Two people, two people in the educational department, the more experience in the clinical setting, yeah.
Okay. Why do you think it is that Asian women have higher risk of DEBI?
Why they have? Well, we are trying to explain it with the data we have. We haven't come out once with a solution yet. We even even using the registry with the usual sample size, we stratify by BMI. See, for each cut point of a BMI or 2-point range, if we compare all the race, and we saw that basically Asian had the risk of a gestational diabetes at the BMI 21, there was the same of those of African American at BMI 35. So, same for macrosomia. They have the macrosomic baby GDM and macrosomic baby at BMI of 21, when the other race ethnicity had the same strength of the association, a much higher BMI. Monique Ederson did some analysis on biomarker collected prior to pregnancy and develop gestational diabetes. She shows some possible difference in the mechanism. For example, Asian were more likely among Asian, the liver enzyme as a marker or liver fatty disease had a stronger association in predicted GDM among Asian than in other race ethnicity, and found, for example, in African America was insulin resistance, and I don't remember what another race was insulin secretion. So maybe different pathway that lead to hyperglycemia. They are the typical insulin resistance, secretion, and insulin hepatic dysfunction. No diet. I want to, and after to you, sorry. Yeah, no, there are very few. I mean, in our population, and in some study we are able to separate them, and of course it's higher, but still we have also done analysis by different type of Asians, and basically we see that, I mean, the Southeast Asian are those at the higher risk compared to that with the East Asian. Oh, thank you. I'm glad you came. He's one of my older mentors. Long time, sorry.
I want to go back to the prevention of GDM in pregnancy. I think I heard you say that most of the interventions, if not all, I don't think it's quite all, but have not been successful.
The prevention of GDM, yeah.
And I think there's one recent consortium, Nordic consortium, that just published a paper a year ago or so that showed maybe a 35% reduction.
Yeah.
But that's one of the few. And huh?
The Riddle study, what was the name? In England. In fact, the Riddle study. But that's data kind of, I was kind to say didn't find a strong association. The analysis were a little bit.
Why do you think that's the case? What do we need to do to actually prevent GDM in pregnancy or reduce it substantially if we haven't been able to do it so far?
I think it's too late to intervene in pregnancy.
You think it's too late?
Yeah. Yeah, so there's the preconception, yeah.
Oh, I see what you mean. Too late to do it while pregnant.
Yeah, because the metabolism, because the placenta has so much influence on the glucose metabolism, and it's something you cannot control with the lifestyle. And not, I'm not a placenta expert, but I mean, I can imagine with but so that's why if you intervene by reducing the insulin resistance during prior to pregnancy, maybe you can prevent GDM. She hasn't done yet? Yes.
Part of your MI protocols, are you guys assessing readiness for change? Because that's a big predictor of anybody's, ability or willingness to actually follow through with a protocol. So feasibility of any type of trial or intervention would highly depend on the proportion of people who are actually in the stage of change that they could adopt.
We do measure, but we don't use it for the intervention. Okay. Yeah, because
the MI isn't.
No, the dietitian they cannot look at. Otherwise, they might will lose that. Yes.
Have you looked at the Asian population and the risk of gestational diabetes in terms of whether they were born in this country, first generation born here, or like second? And the reason I'm asking that is because in the allergy world, which is what I know, if you move the Asian population, let's say to Australia, the rate of allergic disease literally goes sky high. We're now looking to see what happens to the second generation, but trying to control for differences in diet, different environmental exposures. The kids all live in Melbourne, but the Asian kids that's born in Australia, first generation, have got much higher allergy rates. So we can't find diet or environmental reasons for that high risk. And I was wondering if in gestational diabetes being
it's a strong risk factor. Being born outside the United States is a strong risk factor for gestational diabetes. We published a paper by linking with the birth certificate, and we saw in all Asian group as well, except for the Japanese. There was the reverse. And so actually in our population, I think 50% of the GDM cases are born outside the United States. It is true for also the white population. If they're born outside the States, they are at increased risk of GDM.
Last question, perhaps. If you are to contemplate a preconception behavioral intervention, what would you do within Kaiser? Because you have the luxury of having the data. When, and you started like a few months before, a few years before, adolescents.
No, probably. I mean, for feasibility, probably soon after one pregnancy. Okay. So because women when so the first one, your problem. The second one, and I mean, because otherwise, I mean, it's not feasible. I mean, to intervene. I mean, to do a study funded by the NIH that you can intervene so much. I mean,
this is the discussion about the cycle. If it's not pregnancy but preconception, what's the best period preconception to start as couples approach that stage in their life, during adolescence, earlier in life, and so you go all the way back to the vicious cycle, and so wonder. So perhaps there isn't a special moment in time, but attacking the problem.
Oh, at multiple levels. I completely agree. Yeah.
I was wondering, do you have a data for families when you go through the nurse-family partnerships? So in your data, if outside simple lifestyle intervention, but it's a comprehensive intervention delivered by nurse and consistently postpartum 2 years, nurse-family partnership, I wonder in California you have similar programs, and in your subgroups you will have those data to study.
No, I don't think so that we have access to this data now.
Yeah, I think they overlap.
Thank you very much.
Okay, thank you.